Individual risk calculator to predict lymph node metastases in patients with submucosal T1b esophageal adenocarcinoma, a multicenter cohort study. Introduction. Esophageal adenocarcinoma, EAC, is an aggressive cancer carrying a 5-year survival rate of 19%. The most important prognostic factor for survival is the presence of lymph node metastasis, LNM. Radical esophagectomy with lymphadenectomy has long been the standard treatment for EAC, including early cancer. Endoscopic resection is a safe and effective treatment and is indicated for the curative management of early EAC. Additional surgery after endoscopic resection is advocated when the risk of LNM outweighs the risk of mortality associated with esophagectomy. Histopathological characteristics such as lymphovascular invasion, LVI, poor tumor differentiation, and invasion into the submucosa of more than 500 micrometers are associated with a risk of LNM. When EAC is limited to the esophageal mucosa, T1a, the risk of LNM is only 1% to 2%, and radical endoscopic resection of the lesion suffices. When EAC invades the submucosa, T1b, guidelines recommend additional surgical resection of the esophagus and locoregional lymph nodes. The prevalence of LNM in esophagectomy specimens varies between 0% and 78% for T1b EACs and depends on the extent of invasion into the submucosa. Superficial submucosal invasion was associated with variable LNM risk in previous studies, 0% to 22%, while deep submucosal invasion was associated with higher LNM risk, ranging from 26% to 36% to 50% to 78%. In the challenging clinical scenario when LNM is not seen on imaging, management depends on metastasis risk assessment. Not every patient with pT1b EAC develops LNM, while surgery is associated with morbidity, mortality, and decreased quality of life. Endoscopic resection might be a good alternative for selected patients with pT1-SM1 EAC in combination with low-risk histopathological characteristics such as well to moderate differentiation, G1, G2, and absent LVI. Only 1.9% of these patients developed LNM. Other studies also reported LNM risk of less than 2% in patients with pT1-SM1 EAC with low-risk histopathological characteristics. In contrast, the LNM risk is reported to be higher, up to 9%, in patients with pT1-SM1 EAC with at least one high-risk histopathological characteristic, such as poor tumor differentiation or LVI. The European Society of Gastrointestinal Endoscopy guidelines state that R0 resection of pT1-BSM1, G1 to G2, LVI negative is potentially curative, and the decision about whether or not to perform additional treatment should be individualized in these patients in terms of morbidity and mortality risk versus LNM risk. Although many studies have described separate histopathological risk factors associated with LNM, no appropriate clinical tool is available that incorporates all accepted prognostic histopathological parameters to accurately predict the LNM risk on an individual basis. Little is known about how the individual risk increases with the accumulation of more than one histopathological feature. The aim of this study was to develop and internally validate a prediction model based on histopathological variables that estimates the risk of LNM or distant metastases in individual patients with pT1b EAC. Methods. A nationwide retrospective multicenter cohort study was conducted in patients with pT1b EAC treated with endoscopic resection and/or surgery between 1989 and 2016. The primary endpoint was presence of LNM in surgical resection specimens or detection of metastases during follow-up. All resection specimens were histologically reassessed by specialist gastrointestinal pathologists. Subdistribution hazard regression analysis was used to develop the prediction model. The discriminative ability of this model was assessed using the C statistic. Results. 248 patients with pT1b EAC were included. Metastases were seen in 78 patients, and the 5-year cumulative incidence was 30.9%. The risk of metastases increased with submucosal invasion depth, subdistribution hazard ratio, SHR, 1.08, lymphovascular invasion, SHR 2.95, and for larger tumors, SHR 1.23. The model demonstrated good discriminative ability, see statistic 0.81. Conclusions. A third of patients with pT1b EAC experienced metastases within 5 years. The probability of developing post-resection metastases was estimated with a personalized predicted risk score incorporating tumor invasion depth, tumor size, and lymphovascular invasion. This model requires external validation before implementation into clinical practice.